Hello students. Today's discussion topic is pharmacotherapy of hypertension. Before we are starting our topics, I want to share the PowerPoint presentation of this slide. Here, as I told, today's topic is pharmacotherapy of hypertension. So at first, you should know what is hypertension. I think all of you are very well known in these terms. That is the hypertensions. That is defined as a elevated blood pressure. And what is blood pressure? Blood pressure means it is comprised of our systolic pressure and also diastolic pressure. Okay. Here systolic pressure are nomenclated by SBP and as well as diastolic pressure nomenclated by DVP. As we know that when systolic pressure are high as 140 mm Hg and diastolic pressure are higher than the range of 90 mm Hg, this is called as hypertension. Okay. If we are talking about the types of hypertension, then we should talk. This is actually this is two types of hypertension. There is two types of hypertensions are there. First one is the essential and another one is the secondary. So what is essential kind of hypertension? Essential kind means a disorder of unknown origin affecting the blood pressure regulating mechanism. Means a disorder, hypertension basically a disorder of unknown origin affecting the blood pressure regulatory mechanism. And what are them? This will be discussed in later also. This is called as essential hypertension. And secondary hypertension means when hypertension is happen or arise with some kind of associated disease, means secondary or other disease when are present, when this time elevated blood pressure means this kind of hypertension means this is called as a secondary hypertension. And some environmental factors are there behind the pathophysiology of hypertension, which is stress. When your stress is increased, hypertension may be increased. When your sodium intake is increased, then also hypertension should be increased. When your obesity means when you not maintaining your BMI, then hypertension also increased. And other is smoking, that is our means daily routine. When smoking cause hypertension, this is also a factor, also a considerable factor. So these all kind of environmental factors are there which may elevate our blood pressure. This is also cause of the hypertension. Okay. Then what is our normal blood pressure regulatory mechanism? It is a fundamental thing which we should know. So what is our normal blood pressure regulation mechanism, and why we are discussing this point now, normal blood pressure regulatory mechanism? Because when we will study the pharmacotherapy of this kind of antihypertensive drug, then their mechanistic approach or pathway of the mechanistic approach, when we studying or we will study the mechanistic approach of this kind of drug, then it is necessary to known about this kind of regulation, normal regulatory mechanistic pathway. What are they? Now, first one is the what is blood pressure basically? Blood pressure basically is our cardiac output in CO into resistance to passage of our blood through the pre-capillary artery. This is called as PVR. Means blood pressure means CO equal to PVR. This is called as blood pressure. Physiologically, CO means cardiac output and PVR is maintained a minute to minute by arterioles or postcapillary venules or heart. Means there are three kind of component are there. First one is the arterioles, second one is the postcapillary venules, and third one is the heart. So in that process, the fourth site is the kidney. Means what matlab kidney, how kidney regulate the blood pressure? Because kidney regulates the volume of the blood, basically volume of the intravascular fluid. This is also called as blood. And another mechanistic approach, basically when we are studying about this four side, first one, what are they? First one is the arterioles, second one is the postcapillary venules, third one is the heart, fourth one is the kidney. And this above four side are regulated by our baroreflex or baroreceptor. And what is this? Now, humoral mechanism and renin-angiotensin aldosterone system regulates these four above sites. Means baroreflex, baroreceptor reflex, and another one is the RAS system, that is the renin-angiotensin system. And some of the local mediators or local agents like nitric oxides are also involved in this kind of regulatory mechanism. Okay. In hypertension, baroreflex and renal blood volume control system set as a higher level, where as we see in the picture that the in hypertension, baroreflex as well as renal blood volume control system set as a higher volume, and all antihypertensive drugs act interfering this normal mechanism process. Okay. Then if we talking about the baroreceptor reflex arc, then we see in this picture that if or when BP is high, blood pressure is high, then cardiac output means CO basically there is in the lower side, and peripheral resistance or peripheral vascular resistance also in lower side. Then BP is low. In normal, I am talking about in normal mechanistic pathway. Okay. When BP is high, then our baroreceptor, what they do? Now they trying to reduce our CO, means cardiac output, as well as peripheral vascular resistance. And this process is vice versa. Okay. Vice versa means if BP is low, then cardiac output and PR is also in higher side. Then BP is high. Okay. And what are the renal response? Long-term blood pressure control means by controlling blood volume. This is also one mechanistic pathway. Second one is the reduction in renal pressure, as well as you can talk about intrarenal redistribution of the pressure and increased absorption of the salt and water. Third point is the decreased pressure in renal arterioles as well as sympathetic activity, which affect the renin production, and as well as renin, when renin production is happen, then angiotensin 2 production is happen, and as an angiotensin 2 production is associated with the sum of other factor like sodium absorption process, increase in sodium absorption process. When sodium absorption process is takes place, then blood volume will also increase, then blood pressure is also increased. Okay. Then we'll discuss about some of our antihypertensive drug. As we earlier said that our topic is pharmacotherapy of hypertension, then we should talk about antihypertensive drugs. If you talking about first line antihypertensive drug, then you should know about diuretics, then AC inhibitors, then AT1 antagonist, etc. etc. And if you talking about the example of diuretics, then there is thiazide diuretics like hydrochlorothiazide, chlorothiazide, high-selling diuretics, that is the furosemide, potassium sparing diuretics, that is the spironolactone, amyloidite. They act on the kidney to increase the excretion of sodium and water and decrease in blood volume, and as well as decrease the BP. If we talking about the AC inhibitor, then there is the example of captopril, uh, lisinopril, enalapril, ramipril, and what are they doing? Now they inhibit the synthesis of angiotensin 2. And what is angiotensin 2, which I have earlier discussed earlier? Uh, and what happened to if the synthesis of the angiotensin 2 is decreased, then decrease in peripheral resistance as well as blood volume. Our third point is the angiotensin blocker or AT1 blocker. The example of the AT1 blockers are the losartan, valsartan, telmisartan, etc., which are blocks binding of angiotensin 2 and its receptors. Some of the centrally acting drug is here like clonidine, methyl dopa. They act on the central alpha 2A receptors, which leads to decrease the sympathetic outflow. And here is choline BP. Another drug is beta adrenergic blocker. There is two types of beta adrenergic blocker. One is non-selective and another is cardioselective. If you're talking about the non-selective, then propranolol is the example and others are timolol, pindolol, levitalol. And if you're talking about the cardioselective, then metoprolol is the example and others are atenolol, ismolol, betaxosol. And beta adrenergic blockers, basically they are bind with the beta adrenergic receptors and blocks the activity. And if we're talking about beta and alpha adrenergic blocker, then there is the examples of the levitalol and carbitalol. If we there is the another drug that is the also alpha adrenergic blockers are also act as an antihypertensive agent. The example of the alpha adrenergic blockers are that is the prazosin, terazosin, doxazosin, and the mechanistic approach of this kind of drugs are they are blocked or blocking of alpha adrenergic receptor is smooth muscle, and it cause the vasodilatory effect, which leads to low in BP. Okay. Another drugs are calcium channel blockers. This is also called that is the CCB, calcium channel blockers. Examples are verapamil, diltiazem, imidipine, and they act or they blocks the influx of calcium ions in smooth muscle cell, which leads to relaxation of SMCS and decrease the BP. And another kind of drugs are the potassium channel activators, and the example of the potassium channel activators are dioxides, minoxidil, etc., which are leaking the potassium ions due to opening and hyperpolarizations of SMCS or happened SMCS means that is the calcium channel blockers, which are sorry, when we talking about the potassium channel activators, they hyperpolarize the smooth muscle cells and relaxations, and then it is leads to the relaxation of the SMCS, which vasodil other kind of some kind of vasodilators are there. There is the examples of that is the arterial vasodilators like hydralazine and arterioventricular, that is the sodium nitroprusides are there. Then, if we're talking about the first line drugs like diuretics, AC inhibitor, or AT1 antagonist, so I would like to describe elaborately this kind of drugs and their pharmacotherapy against the hypertension. Okay. Diuretics causing net loss of water and urine in water, which leads to initially they leads to diuresis, depletion of sodium and body fluid volume, decrease in the cardiac output. Subsequently, after 4 to 6 weeks, sodium balance and cardiac output is regained by 95%, but BP remains low. Okay, these are the mechanistic approach or pharmacological actions uh, of the diuretics. And if we tell why, sir, why this is so, then I will tell you reduction in total peripheral resistance means TPR due to deficit of little amount of sodium and water, which NA cause vascular stiffness. Okay. And similar effect is seen with sodium restriction. Means if we restricted the sodium entry or if we restricted the intake of sodium, then BP is automatically regulated or well managed. Okay. If we're talking about some adverse effect of diuretics, then we should know uh, the adverse effect of thiazide diuretics uh, that are hypokalemia, means muscle pain and fatigue, hyperglycemia, which leads to inhibition of insulin release due to the K plus depletions, hyperlipidemia, rise in total LDL level, which is increase the risk of stroke, hyperuricemia means inhibition of urate excretion, sudden cardiac death, etc., etc. Okay, but it is observed that these adverse effects are minimal with low doses. Means if you taking the low dose of diuretics as like 12.5 to 25 mg, then average fall of BP is 10 mmHg with minimal or with uh, lowered associated adverse effect. Okay. And what are the current status of thiazide diuretics in pharmacotherapy of hypertension? If we're talking about that, the effect of low doses, no significant hypokalemia, no incidence of arrhythmia, lower incidence of hyperglycemia, reduction in MI incidence, and reduction in mortality. Where JNC recommendation for the antihypertensive therapy, then JNC 7, actually JNC 7, which recommends low dose of thiazide therapy, that is the 12.5 to 25 mg per day in essential hypertension. Preferably should be used with potassium sparing diuretics as a first choice elderly. If you administer the diuretics elderly, then the first choice of drug or diuretics should be potassium sparing diuretics like spironolactone. Okay. If therapy fails, in that case, another antihypertensive, but do not increase the thiazide dose. If this therapy fails, then if you are doing the or if you administer the dose largely, then associated effect of adverse action is high, then you should or we should recommend the dose between 12.5 to 25 mg. In case of fail, if you started, or in that case you can start another antihypertensive drug with thyroid. Okay. Loop diuretics are to be given when there is severe hypertension with retention of body fluids, but basically loop diuretics are not given in antihypertensive as an antihypertensive drug. Basically, thiazide or potassium sparing diuretics are the preliminary choice of the drug, and where loop diuretics are used when there is massive hypertension with retention of body fluids. Okay. Then angiotensin converting enzyme. Before we going to these topics, that is the ACE inhibitors, we should, or I would like to describe elaborately the renin angiotensin system, means RAS system. Okay. So what are the physiological background? RAS introduction. Renin is the proteolytic enzyme. Is called as angiotensinogenesis. It is produced by, there is the JG cell, that is the juxtaglomerular cells of the kidney, and it is secreted in the response to decrease in arterial blood pressure. When arterial blood pressure is decreased, then renin is secreted, decrease in sodium in macula densa, and increase in the sympathetic nervous activity. If sympathetic nervous activity is increased, then also renin was produced. Okay, renin acts as a plasma protein, that is the angiotensinogen synthesized and secreted into the bloodstream in the liver, and cleaves to produce a decapeptide, that is the angiotensin 1. Means renin bind with the angiotensin and they cleaves and produce a decapeptide, which is called as angiotensin 1. Then angiotensin was rapidly converted in angiotensin 2, which is a octapeptide by the presence of ACE, which is an enzyme. Then furthermore degradation of angiotensin 2 to angiotensin 3. Both angiotensin 2 and angiotensin 3 stimulate the aldosterone secretion from the adrenal cortex. And whereas when we're talking about the AT2 has very short half-life, that is the 1 minute. And this is the diagrammatical representation of the RAS. As we talk about the when vasoconcentration are there, sodium water retention are there, increased in blood volume, then renin production has happened. Renin was the production of the angiotensin 1 and the presence of angiotensin converting enzyme. Angiotensin 2 is there, and angiotensin 2, when angiotensin 2 is produced, then it is caused vasoconstriction as well as rise in blood volume, which leads to blood pressure. Okay, and this is the mechanistic approach of the ACE inhibitor, where we am trying to deliver that the angiotensin where ACE inhibitor is act. Okay, and AT1 antagonist as act. There is the ACE inhibitor in hypertension, captopril, that is the sulfhydryl containing dipeptide, and abolish the pressure actions of the angiotensin 1 and not angiotensin 2, does not block AT receptors, and these are the pharmacokinetics. What is the adverse effect of the captopril when we talking about? That is the persistent cough or persistent Brazil cough in 20% cases. Inhibition of bradykinin and substance P breakdown in lungs. Because of inhibition of bradykinin and always a substance P breakdown in lungs is occurred, then persistent Brady cough is there. Though it is happened only 20% of cases, but it happened. Hypokalemia in renal failure patient with potassium sparing diuretics. Hypotension, that is the sharp fall may occur. Acute renal failure, angioedema, rashes, dysgeusia, proteochemic contraindication. Captopril should not be given with in pregnancy, bilateral renal artery stenosis, hypersensitivity, hyperkalemia, etc. And what about enarapil? It is a product converted to enarapilate. Advantage over captopril is the longer half-life than captopril. Absorption not affected by food. Rash and loss of taste are frequent. Longer action, longer onset of action, as well as less side effect. ACE inhibitor, that is the remipil, it is a popular ACE now. It is also product with a long half-life. Tissue specific means protective of heart and kidney. Uses diabetic with hypertension, CHF, AMI, and cardioprotective in angina pectoris. AC inhibitor, that is the linsoppril, it is a lysine derivative, not a product. Slow oral absorption, less chance of first dose phenomenon. Absorption not affected by food and not metabolized, excrete unchanged in urine. Okay. AC inhibitor and hypertensive, if we talking about the first line of the drug, no postural hypotension or electrolyte imbalance, no fatigue weakness, safe in asthmatic and diabetic patient also. Prevention and secondary hyperaldosteronism and K plus loss, renal perfusion well maintained. Reverse the ventricular hypertrophy and increase the lumen size of vessels. No hyperuricemia or delistemia effect of the plasma lipid profile. No rebound hypertension, minimal worsening of quality of life, general well-being, sleep and work performance, etc. etc. If we're talking about the ARB, that is the angiotensin receptor blocker, specific angiotensin receptor have been discovered, grouped or abbreviated 82 as AD2. They are present on the surface of the target cells. Most of the physiological actions of angiotensin are mediated by AT1 receptor. Transducer mechanism of AT1 inhibitors in different tissues for different mechanism. For example, that is the PLC, means IP3 DAG intercellular, which cause the CA2 plus in release mechanism, and vascular and visceral smooth muscle contractions are there. In myocardium and vascular smooth muscle, AT1 receptor mediated long-term effect and MAP kinase and other. Okay. If you're talking about the losartan, which is a specific AT1 blocker and competitive antagonist and inverse agonist of AT1 receptor, do not interfere with other receptor except TXA2. Blocks all the action of AT2, vasoconstriction and sympathetic stimulation, aldosterone release, renal action of salt and water. Okay. And where is no inhibition of ACE? If we're talking about the losartan, then theoretically superiority over ACI, means angiotensin converting enzyme. Whereas CAP is rare. Complete inhibition of AT1 means alternative remains with ACE. Result in indirect activation of AT1 means vasodilation. Clinical benefit of ARBs over ACEs are not known. However, losartan decreases the BP in hypertension, which is long period of 24 hours. Heart rate remain unchanged and CVS reflex are not interfered. No significant effect in plasma, lipid profile, insulin sensitivity, and carbohydrate tolerance, etc. are there. Mild urocosolic effect is there. Okay. Then, if we're talking about the beta blockers, means beta adrenergic blockers, then non-selectives are there and cardioselectives are there. All beta blockers similar to antihypertensive effect, irrespective of additional properties, means reduction in CO but no changes in BP or initially blood slowly. Adaptation of resistance of vessels chronically reduced to CO and hypertensive access. And other mechanisms are decrease in renal release from the kidney and beta associated or beta mediated reduced in NA release and central sympathetic outflow. If you're talking about the beta adrenergic blockers, then advantage of the no postural hypertension are there, no salt and water retention, no incidence of side effect, low cost. The drawbacks of these drugs are fatigue, lethargy are happened, loss of libido, cognitive defects, and difficult to stop, certainly. Advantage of cardioselective over non-selectives are in asthma, it can be easily used. In diabetes mellitus, in peripheral vascular diseases, the current status of this drug, which is recommended by GNC 7, first line of antihypertensive drug along with diuretics and ACEI, and preferred in young non-obese hypertensive patient, angina pectoris or post angina patient, most post MI patient. Okay. So this kind of drugs, or if you're talking about the beta cardioselective blockers, are more recommended or first line antihypertensive drug along with diuretics and ACI, etc. etc. Okay. Then, if we talking about the calcium channel blockers, basically, uh, the advantage of this kind of drug, only unlike the diuretics, no adverse metabolic effects, but mild adverse like dizziness, fatigues are there. The current status of this drug are as per the NC, CCB are not first line drug of antihypertensive unless other indications are used. Okay, so that's why we are not uh, elaborated this drug as a antihypertensive. And another important drug is centrally acting drug. Why I am discussing that drug, that is the alpha methyl dopa, because it is used in pregnancy, which are not basically contraindicated in pregnancy like other first line of drugs. Okay, so this is my topics here. I have completed this topic. Hope all of you are enjoyed this topic, and thank you. Good day.